In the world of queer family planning and creation, it's no secret that the whole process can be extremely expensive, and for many, it's prohibitive. Today, I have the opportunity to introduce you to Dr. Sue Ellen Carpenter, a reproductive endocrinologist from Bloom Fertility in Atlanta, Georgia. We talk about breaking down the costs and making things more piecemeal for those who do not have insurance coverage to help them through their process and on their journey. We also talk about some of the latest technology using INVOcell to reduce costs and actually involve the clients more personally on this whole journey. Welcome to the Becoming Baby Ready podcast, your podcast for queer family planning. My name is Sam, and throughout this podcast, you'll hear me have conversations with professionals who work alongside people who want to start and grow their families, as well as parents of intentionally created families. Everyone I speak to identifies as being part of the 2S LGBTQIA+ community. This is your opportunity to learn answers to questions you didn't even know you had. Welcome, everyone. Today, I'm going to turn things around a little bit. I'm going to do things just a little bit differently. As you know, if you've been listening to this podcast, up to this point, I have only ever interviewed and spoken with people who identify as being part of the queer community. Dr. Sue Ellen Carpenter is my guest today, and she is the face of Bloom Fertility in Atlanta, Georgia. And while she does not identify as being part of the queer community, she considers herself to be incredibly open and welcoming to helping members of our community create their families. And so it is with that I welcome you today. Welcome, Dr. Carpenter. Tell us a little bit about your practice and how you got into the space that you're in now with Bloom Fertility.
So I had a long career in traditional reproductive endocrinology, both academically and in private practice, and was very proud of the work that we did, but always frustrated by the fact that it was only getting more and more expensive. And there were many patients who would have benefited from access to care and simply couldn't afford it. Especially as I'm in a state where there is no insurance mandate for care. So I was given an opportunity to reinvent myself during the pandemic, actually, and create an environment that I had long thought about for offering actually cash-based care at a much better price point to patients. What you find when people are accepting insurance contracts is that the patients who don't have coverage pay for that coming and going. They pay for there being a business office in the practice that's big. And the insurance contracts are often written at 60 cents on the dollar or less, and then prices go up to compensate for that. And so I had often thought that there might be a role for running a practice that didn't need particularly a business office, and where we could improve the transparency with regard to pricing and be very straightforward about what each element of care would cost. And that has proven to be true. And in the course of that project, I looked at a lot of ways of trying to reduce costs, some of it by limiting the amount of medication that we use. Not everybody needs everything all the time. And then using less medicine, both in the setting of IUI and of in vitro fertilization, means fewer office visits, which helps financially. It also helps in terms of how inconvenient care is. We live in the Atlanta metro area is very large, and you can be 10 miles away, and that could still be a 45 or 60-minute drive. And
Sure.
so the fewer visits a patient needs to the office, the better. And then with regard to in vitro fertilization, we adopted a strategy that's common in Europe, and it was common in the United States at one time, where we do egg retrievals using pain medication, oral medicine, Valium, Tylenol, and some local anesthesia instead of full-on general anesthesia. And we find that it's quite good. The retrievals actually take 10 to 15 minutes or less. And while it's not perfect pain control wise, we think it saves overall several $1,000s. And one of the big bonuses has been that it allows partners to be in the room with us. And I really love the extent to which that makes this a family effort and the transparency that it adds to what we're doing. And then probably the single biggest thing was our adoption of this device called an INVOcell. And the INVOcell takes advantage of a woman's body temperature and movement to culture the embryos instead of culturing them in an incubator. That space and technology and embryology time is very valuable. And so being able to use the INVOcell both brings the cost down and also makes it a much more intimate experience for families. I think patients love the fact that we have only their eggs and their sperm in the lab at one time, and then they carry their embryos for 5 days and return to see how things have developed. So that was, I think that pretty well summarizes all the things we started out doing to try to reduce the cost of care. And then what brought me to you is the fact that we discovered along the way that this was a great strategy for lesbian couples and for single women who might want to do reciprocal IVF, where in this situation, one woman can generate the eggs and we retrieve them. Either partner can carry the INVOcell and the other partner can carry the pregnancy. And it's been, especially given how expensive donor sperm have become. At one time in my career, reciprocal IVF was felt to be too much technology. If there wasn't a medical need for IVF, it was frowned upon as sort of designer care. But now that sperm are so expensive and IUI pregnancy rates are fine, but they just aren't going to be higher than 16 to 20% per cycle. And so doing multiple cycles of donor insemination often is more expensive than a single cycle using the INVOcell. And so all of it has come together to make this, I think, a really attractive option in the queer community.
And it has, and certainly not naming names, that is also part of how we've connected, is that one of your past patients has been someone that I have connected with, and they were extremely excited to tell me about their INVOcell journey and make sure that you and I connected, because they feel as though your clinic was very welcoming to them, very receptive to all of it, and provided them with the best options for them that they could both afford, but could also emotionally connect so that both people could carry the embryos at different times, which is just so, it's just so amazing. And there's so many things that you've said that I want to unpack, but I want to go back quickly to, because I think a lot of people sort of, I want to talk about the fact that you're doing retrievals without general anesthetic. So I'm going way back in what you were talking about, but
yeah, absolutely.
But I think I think it's an important step, because I think as a world, we often become complacent about the way that things are done, and we don't think about the side effects or the potential complications that arise. But certainly when we see someone having a cesarean section for a birth, we know that the preference of the care team is to keep the birthing person awake if at all possible,
Yes.
because there is inherent risk to having someone sleep through a procedure and then having to wake them back up. So, do you see overall the outcomes be more favorable from that perspective too? That not only can you keep costs down, which is fantastic for the people who are paying out of pocket, but you also remove a level of risk. Do people take that into consideration when you keep them awake, even with mild sedation? They may not be awake and fully alert, but they aren't asleep.
Correct. And it is safer. I don't know that I choose to emphasize that point because
Right.
I think the anesthetic that I've been associated with in the past was well done. Uh,
Right.
but safety is an aspect of it. That is the truth. And I guess my patients see it. I still have them fill out a pretty traditional form about risks of anesthesia, both consent forms, but also kind of medical history. And it's honestly pickier. There are things that aren't important when you're awake that are on that list. And I say, don't, I understand this list may seem overblown for what we're actually doing
Sure.
isn't that great.
Mhm.
I'm not going to have a problem if you've got dentures or if you've got contacts in because you're going to be aware of that and managing it for yourself.
Right.
But I have never wanted to leave those things out. I'm still appreciate having all the information. And so I
Mhm.
think in that sense, at least, patients realize that they're gaining something real from um, avoiding those risks.
Sure. And I guess I should qualify what I was saying, that we're grateful that general anesthesia exists for a variety of different procedures. So I certainly don't want to suggest that no one ever wants to be provided general anesthetic, but if you can be conscious, and as you say, it's a relatively brief procedure. So if you can kind of come in and have it done and then be back on with your day in a shorter period of time, then you're coming out potentially financially further ahead because you're not having to take as much time off work and that kind of thing as well.
That's true. And I just love that we can communicate through it. And I think, when you talk about general anesthesia versus epidural or spinal, for example, for a C-section, yes, it's about risk, but it's also about, in that case, it's about bonding with the baby.
Sure.
Uh, in my case, it's about knowing how the egg retrieval went, partners being in the room with us.
Hmm.
Um, and just overall a less medical environment. There's no IV involved, there's no stretcher involved. Patients walk in, they get themselves positioned the way they're comfortable being. There's not a risk that they'll be asleep and we'll put them in an awkward position with regard to their neck or their back or their hips.
Yeah.
Um, and then because of the way we handle the INVOcell, they rest after the retrieval in the procedure room for about a half hour and walk back out. They go to the restroom and they walk out the door. Probably we've done about 400 cases, and maybe we've taken a patient down in a wheelchair once. We have a wheelchair. I more often borrow it when my mother is in town than I've ever used it for a patient. And we're in a big non-medical commercial office space in Atlanta. And nobody knows that our what our patients have been through. It's all very private and under the little bit behind the curtain, but um, I think it's been much more gratifying and a much more. I mean, I looked at it with some intrepidation to start with, as you can imagine. I had
Sure.
done this with anesthesia, and I also would say, and I think it's important. I believe that there are only 2 or 3 patients in all those cases where I felt that I had to leave eggs behind because they weren't tolerating the procedure well. Um, and that I'm always sorry when that happens. It's sometimes I can see it coming. I know ahead of time that an ovary might be likely to be behind the uterus and that we might have to go through the uterus to get to it. And I would offer those patients. I know it ahead of time so that I can offer them. They need to leave me. I truly don't have the what you would need to do anesthesia here safely. It's just plain not an option here, but there are certainly plenty of programs in Atlanta who do it that way. And so if I felt that somebody really wasn't going to tolerate it, or had ovaries, I've had a couple people who've had ovaries in places I knew I couldn't get to, then they're just not candidates for what we do, and that's okay. But one of the things I do ahead of time is just a basic ultrasound of the ovary with that in mind.
Sure.
How easy or difficult will it be to get to the ovary?
That makes perfect sense. And that's just being done out of respect for the work that you do and for their own healthcare. So that
Right.
makes sense. That makes perfect sense to me. So you talked also about the fact that so much of reproductive health and fertility and things like that is rooted in insurance, and a lot of people rely on their insurance, and you've broken it down so that if someone doesn't have insurance, they can work with you through pieces and pay in pieces to have different parts of the process done. And we are getting to INVOcell because it is just such an amazing and interesting thing. But before that, do are people who do have some insurance still coming to you and then taking and submitting for themselves what little bits that they can retrieve, or do you only exclusively
Yes.
treat people who don't?
Well, so I tell patients very upfront that we don't file insurance
Right.
and encourage them to research their situation. Um, I have had patients that I have sent from here because they had coverage and I had an attachment to them. They had an attachment to me, but they really got to a point where they needed IVF and they had coverage. And they just got to go someplace to use your coverage. And I've had a few of them come back because actually our prices were still lower than their price using their insurance at a more traditional setting. And that has to do with how deductibles are written and
Sure.
limits. And so there's that. There are patients who have coverage, and we have a preferred pharmacy that we use most frequently, but are not wedded to that. A patient
Mhm.
could use any pharmacy. So if their insurance has a preference on that, we send their prescriptions anywhere. And if INVOcell treatment, the treatment itself is about $6,500, and the medication is often $3,500 or $4,000. So when I say that I often can get this done for $10,000 American, um, a lot of that is medicine. And so
Mhm.
even people who have coverage that I'm not filing for the procedures might be able to use it to get their medication.
Right.
And then I do encourage patients to ask whether they have out of network benefits because
Mhm.
I'm not going to be in network no matter what, but
Right.
often people can get reimbursement. And so, and then, and I don't know how exactly how it looks in Canada versus here, but the other part of this is that often we can find a way to get testing covered. We distinguish between testing and treatment.
Hmm.
And so when I speak with the patient the first time, if they haven't encountered this problem before,
Hmm.
their first call needs to be to their insurance. And I just coach them to say, now you need to call
Hmm.
and ask if you have coverage for infertility testing.
Hmm.
And if you do, then you ask if you have coverage for infertility treatment. And if you do, then you need to know is does it cover IUI? Does it cover IVF?
Hmm.
Is there like an annual dollar limit or a lifetime dollar limit?
Right.
And then C, what the answers to those questions are, and many times people just really have no idea. They've never encountered this concept. And
Right.
so they go off to find those things out and let us know what they learned, and then they'll be back, or I have colleagues obviously in the community in traditional programs, and I try to make sure that we can expedite their trip to a place where their insurance coverage might work.
Yeah. And that's the thing. Sometimes we need to look for the loopholes so that we are able to help as many people create the families of their dreams as we possibly can. And that's just a fact.
And I don't want to leave money on the table by not using their insurance. So I
Sure.
do, I mean, my niche is for the people who are uninsured for
Right.
this.
Yeah.
And we're pretty clear about that. But then there are some gray areas still.
Sure.
The thing that used to really be frustrating about coverage was a patient calling her insurance and asking if she had coverage for ultrasound. And the insurance says, of course you do. Your doctor is just coding it incorrectly.
Mm.
And they want it coded as polycystic, as their underlying diagnosis for which they have coverage.
Right.
But which might be endometriosis or polycystic ovarian syndrome, whatever. But if it's in the service of fertility treatment, that's fraud. And
Right.
the insurance company comes back to the providers with that. And being a provider caught between a patient and the person they call on the phone for information was always just one of the most galling things.
Yeah.
And I can't tell you how much for myself and for my team being out of that environment has been healthy.
I can only imagine, but I have from other work that I've done, I have a good indication, and it's hard because you just want to help people.
Right. And there were big programs that were ultimately sued for fraud, and they were absolutely just trying to help the patients. There was no doubt that that was their motivation, but it comes back at you.
Hold on for just a moment. We'll be right back. You know about babyREADY because you're listening to this podcast, so you know that we are all about queer family planning and helping you have the family of your dreams. But did you know that we don't abandon you once your baby arrives? We actually offer parenting coaching as well, and that's not just for the newborn phase, although we are there for that, but it's through toddlerhood and young children, tweens, and even through the teen years. When you need someone unbiased to lend an ear so that they can hear where your struggles truly are and help you come up with a path and a plan that feels truly right for you and your individual family, don't hesitate to reach out. We are always happy to be there for you. Visit us at www.babyready.info for more information. So, INVOcell is what? Take me through. I mean, I have seen it. I've actually seen you hold it in your hand, but
yeah, I think we should just show it, right?
I'm really sorry to interrupt, but if you visit my Instagram page, babyREADY LGBTQ, then you will see a series of photographs that I have taken and put together in the advert for this particular episode so that you can see what it is that Dr. Carpenter is holding.
So this is an INVOcell, and it looks large when I hold it up to the camera.
It does.
Because of the magnification of the camera, but notice that it's really the size of that last joint of my thumb. It's a little bit of I would call it a shorter, slightly wider than a tampon. And it is made out of a medical grade plastic. And the point of this device is to keep sterile the inner workings of it. This little cone is really where the magic happens. And it has a tiny little hole in the top. I got to make it so that you can see the tiny
There
hole
you
that
go.
the
Yeah.
embryologist works through.
Yes.
And the cone itself, on the day of the egg retrieval, the cone has embryology media in it, and it's been sitting in an incubator and it equilibrates for temperature and pH and carbon dioxide. And then I do the egg retrieval. The embryologist does ICSI. We inseminate each egg using intracytoplasmic sperm injection. And during that time, the patient's recovering from the retrieval, and she's just awake and resting in the procedure room. And depending on how many eggs, the insemination takes 30 to 45 minutes. And then the embryologist calls me back, and I witness her pick up the eggs with a glass pipette and place them through this hole. And she's under a microscope. I can see it on a monitor. And
Okay,
we
okay.
say, okay, we have 10 eggs that were inseminated, and we'll watch and count 1 through 12 that they're in place here. And then the embryologist, the top of this twists to seal it, and she tests it with her pipette. And this little capsule has a kind of a little throne in the bottom
Mm-hmm.
for sitting up the cone. There's an O-ring here that seals it. And then it's hard to see, but there's a little slot here on this canister that gets the patient's name in it, which is great. And
Mm.
then she hands it to me. And it comes with this device that we call a retention device. It's basically like a menstrual cup or a
I
diaphragm
was going to
with,
say an old school diaphragm is what that makes me think of.
that's right. I would say that the material is nicer than old school diaphragm. There's no,
Mm-hmm.
some diaphragms had coils and stuff. This
Mm-hmm.
is very soft. And I make a little taco basically
Mm-hmm.
out of this and place it in the patient's vagina. And my putting it in is awkward as it goes in. But then once it's there and I can take my hand away, patients will say that they either don't feel it at all or they're aware of it, but it's not uncomfortable. And then we're done for the day and the patient's wide awake. By that time, she's a half hour or more away from the retrieval and all more than an hour away actually from the oral Valium and Tylenol and narcotic. And she gets up and goes to the restroom, proves that the device is in place and comfortable enough, and and home. And God,
No, I'm looking at that and it's a reasonable sized device
yeah,
and the diaphragm looking cup or menstrual cup does the cervix go in there as well? Like are they sharing space, the cervix and the INVOcell within that cup?
it's really in the upper vagina, and the cervix is generally, I'd say, a little bit above it.
Okay, okay.
It's sitting in the vagina, and
Okay.
when you put a menstrual cup in or a diaphragm, the cervix really was inside it.
Yes, yes.
I would say that's not the way this usually
Okay.
sits. Usually, this sits below it.
Okay.
It does, the pubic symphysis is right here, and fitting it just behind there is a good way, sense that it's in a good location and will stay there.
Mhm.
Um, but the cervix is usually a little above it.
So fascinating. And then it just sits there for the 5 days or so that the patient
Right.
wears it.
It was originally first approved FDA certified for 3-day culture
Okay.
and a couple of years ago and had been, we often use things in medicine ahead of when they're fully certified
Mhm.
and so it was being used for 5-day and then that was all presented to the FDA and it is now certified for 5-day culture. And the patient comes back, and I just reach in over the lip of this and pull, and usually it all comes out together.
Hmm.
This goes in the trash, and we dry this all off and open it and confirm the names. And then embryology, I'm in the procedure room usually when we're doing this, and the embryologist comes in and takes this, which is still sterile, into the lab. And then
Hmm.
it's in reverse order. She retrieves all the eggs, they always all come back. And so she uses another pipette, retrieves the eggs, and then puts the embryos into a petri dish, and we start to look at their stages of development. And um, actually, the anecdote about this thing is that somebody in France retrieved eggs and the power went out, and he didn't know what to do with them
Oh,
and put them in a test tube in a patient's vagina. Now, no information about whether they got pregnant, but that was presumably the seed for
right.
how this got started. And then obviously it's more and more refined. I think it appeals to a lot of patients who feel anxious about their embryos being in an IVF lab. They would really much rather have them be with them than in a lab away from them.
Hmm.
Um, and we see one of the big differences when you do traditional IVF, um, embryologists look at the embryos on day one, which is the day after insemination, to see which eggs have inseminated, have fertilized. And then they tend to look at them again on day three and identify the cleavage stage embryos. So at that point, probably day, 4 to 12 cells, let's say. And then they look at them again on day 5. But they're not intervening at any of those stages. They're just making the observations. And it's a nail biter for us when we first started doing this that we weren't going to get that information.
Hmm.
It's a
Hmm.
little like Christmas morning. You pull out the INVOcell after 5 days, and that's the first you know of how it's been going. And I would say that we generally paid at least lip service to the fact that taking the embryos out 3 times to look at them might have some impact, but they were obviously growing. And
Sure.
so the information was deemed to be worthwhile. We get some really beautiful, particularly cellular embryos out of the INVOcell. And we do think it may be a bit of a testament to the fact that are leaving them alone.
Hmm.
Uh, it may be that a woman's body motion in her normal day-to-day activities help the embryos. And so we are frequently really amazed by how well this goes. When we open it, we're going to see some variety. So if we put in 10 eggs, we're going to expect to see a couple that didn't finish the fertilization process,
Hmm.
and a couple that grew for 2 or 3 days and stopped. And then on day 5, we're going to see a normal range from what's called a morula, maybe about 75 or 80 cells in a solid ball, through a fully hatched blastocyst.
Hmm.
We're looking to transfer a blast or two if we can.
Hmm.
We do have the incubators. So if we take 10 out and 4 of them are in varying stages of development, we want to keep them over till day 6 to see if some can be frozen. We have that capacity.
Right.
So we do a transfer on day 5 if that was our plan. We don't do a lot of PGTA because we know not everybody needs it and not everybody can afford it.
As I say, that's
Um,
another cost when we're looking at costs,
exactly.
right?
So to the extent that it didn't really fit into our financial model, we don't do as much of it as is often done in a traditional lab. But we can do it. We have the expertise to do it, and we have done it, and we get reliable results.
Excellent. Excellent. Are there are there statistics to say that INVOcell is more or less successful overall in helping harvest healthy embryos and blasts at day 5?
Yes. The data that went to the FDA was identical. And it
Excellent.
included, I mean, I think every patient has whatever issues that patient has.
Sure.
The male factor exists, the endometriosis exists, the age of the patient makes a difference.
Sure.
But when you're comparing apples to apples, the INVOcell was equivalent to and that is how it was certified
Excellent.
for 5-day culture by data that showed that it was comparable.
When you and I spoke before, you were saying that you're not the only facility that uses INVOcell, but it's not widely used. Is it because this is going to sound like I'm not trying to sound conspiracy theoristic, but is it because it just literally is a more cost-effective way of doing it in other places, or is it that they want to have more of their I's to dot and T's to cross? If it's happening in a lab and we can monitor in a lab, then we've got our checks and balances. And when we use an INVOcell and we put it in somebody's body, we have to cross our fingers and hope that everything goes well. Like, why is that?
I think it's all of that.
All of it.
And it was not as well accepted as it could be. I think you have to get doing it and you have to make yourself do it, both as an embryologist and as a physician. My motivation for doing this originally was financial for patients.
Right.
And there are a few places around the country that routinely do both.
Okay.
They usually set up somewhat artificial barriers. They'll say this is appropriate to the quote slam dunk patient, usually a woman who was really fertile, who's had a tubal ligation and wants more children.
Right.
They'll exclude patients who need ICSI for any reason. They just say, well, if you need that, then you need traditional IVF. But there's not really a why for that. It's just a choice they made.
Yeah.
I happen to make the opposite choice. I wanted this to be as streamlined as possible and to get in a groove with it, and therefore don't do any conventional insemination because I went and the most recent big summary by the ASRM says the only reason not to do it is expense and lack of expertise. Well, we took the expense out and we have the expertise. So there's presumably not a downside. There were a couple of clinics in the country that intended to do all INVOcell. There are a couple of clinics in the country that choose to try to do high volume, low cost IVF. And I respect that too. They just took an approach to their lab culture to be able to make it less expensive. They chose to make less money per case, and it didn't require the INVOcell for them to do that. Right. When I started this, the INVOcell company that I was working with said, well, do you want to be doing some traditional IVF? And at the time, I felt that it would be a mistake for us because that was our comfort zone. Right. And I could just imagine that we'd have done 10% INVOcell and 90% traditional IVF. Yeah. I do accept the fact that my patients have to be a little bit gritty. Sure. This is probably not for everybody. And so the whole idea of awake egg retrievals and carrying an INVOcell, and for the most part, the motivation starts out being financial. I think that people do look at our reviews and they come here to find out what's going on because of our hands-on approach and how we get to be especially small in terms of our team
Mhm.
because of really a lot because of the cash pay and a lot because of fewer office visits. And I think that just increases people's comfort level and they come to it. But it is likely self-selected that
Mhm.
patients who can't stand that thought are are not here.
Right.
And that's fine. I have chosen not to do egg freezing, for example, because a lot of patients who would be young and sort of not have been around medicine a lot are better served by using high dose, getting as many eggs at a time as possible, and general anesthesia
Mm.
lends itself to that.
Sure.
And so there are some situations where I've thought, this is not right for you, the patient.
Yeah.
Um, and I almost think my patients should have some financial motivation for being here. If really what they want is to be doing 25 and $30,000 IVF
Mhm.
because they on some level really think there might be something better about it, that's what they should do.
Yep.
And so the people I really want to serve are the patients for whom this is truly the best option all the way around.
Mhm.
Um, so
Yeah. And I love that you are providing them with an option so that all levels of people, so many different people, have the opportunity to create their family.
right,
And for many people who thought that it wasn't going to be an option for them.
right.
It's pretty amazing.
It's been rewarding. I
I
think
have
all of us would say that.
I have no
And
doubt.
our patients they're grateful. And they're grateful that we think about it differently.
Mhm.
Um, and that has been a lot of patients in traditional settings are chronically just frustrated and stretched to the bone financially and feel, they have to tolerate a lot. There are ups and downs in this for every single person.
Yeah.
And if on top of that you feel like the practice might or might not always have your interests at heart,
Mhm.
and I don't think there's any question about that here.
Mhm.
There's no doubt that we're here for the patients, and that although things don't always go perfectly, they never do in this field.
No,
Um, there should never be any question about what our motivations were.
that's a that's a pretty amazing way to wrap up our conversation today. And I
Good.
am just, I've said this before when you and I spoke, I'm grateful for you being out there. I'm grateful for the work that you do, and I'm grateful for the commitment that you make to anyone who wants to create their family. Not the least of which, in my eyes, is the queer community of which I am a
Right.
part, but certainly anyone who wants to create a family. Can you just give a quick shout out to the ways that people can find you on the internet and in social media? What are some of your handles so that people can learn a little bit more about you and about Bloom Fertility?
HelloBloomFertility.com is our website. And that is also our Instagram ID and our Facebook ID. Um, and those are clearly the best ways of doing it. If you want to know more about INVOcell, invobioscience.com is the website for the INVOcell. Um, and we obviously we do our best to answer the phone every day. We have but many patients just reach out on the contact sheet and we call them back. There's a contact through our website that is super useful. And once patients are here, I'm very proud actually of our um, electronic medical records platform because we have really direct communication between me and each of the nurses and the patients. And the telephone's a barrier to all that,
Sure.
frankly. And this means that I don't have to call a patient at an inopportune time.
Right.
They don't have to wait on hold to talk to us or reach a busy signal. We can directly communicate and in our own words, really readily. So we do. I love when people just reach out on the website for appointments or if they have questions about what we do, because it really does work well.
Absolutely. That's amazing. And the fact that you are so interested in getting back to people to make sure that they're not sitting with their questions unanswered is a huge part of feeling as though your care team is not seeing you as just a number.
Yeah.
Yeah. And none of us want that.
I like that I can write it and they can hear it in my own words.
Absolutely.
And sometimes you still need to talk, of course, because you need it back and forth faster than that. But
sure.
The fact that they can have it in writing to refer back to is also really great.
Absolutely. When we're getting medical information of any kind, it's nice to see things in writing so that because we can only hear and process so much at a time.
Right.
Right. Absolutely. I will let you get back to your day. I want to thank you so much for taking the time to be here.
Thank you for welcoming us. I appreciate it.
Happy to do it. And for those who are listening who are curious about what an INVOcell looks like, I have taken some screenshots. I will be putting those in the advert on Instagram and TikTok about this episode. And I will also see what I can do to throw a few out there in a couple of other places so that you have a chance to see just exactly what she's talking about, because it is fascinating. It's all fascinating.
Great. Thank you.
Thanks so much.
Have a great day, Sam.
You too. As a queer individual with colonial lineage, I want to first acknowledge the land upon which I live and work. Being from what is now known as Burlington, Ontario, I recognize the original ancestry of these lands as they span from Lake Ontario to the Niagara Escarpment and beyond. These lands are steeped in Indigenous history that benefits my community every day. The territory is mutually covered by the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy, the Ojibwe, and other allied nations to peaceably share and care for the resources around the Great Lakes. I would like to acknowledge that the land on which I stand is part of the treaty lands and territory of the Mississaugas of the Credit. The land dictates everything about our ways of being. Particularly, the land teaches us about fluidity. Concepts of the binary system and heteropatriarchy were imposed by the colonials who were, at the same time, removing children from their homes, families, and all that was familiar to them. These same children were divided by the only two prescribed binaries recognized by the settlers, and they were forced to conform to a performative, gendered falsehood. The land doesn't operate under binary thinking. It is diverse, complex, and unpredictable at times. Rather, the land holds us and all of our remarkable paths and identities. Every organism and spirit has a purpose. It is from this understanding that I strive to live and grow. Thank you for joining me today on the Becoming Baby Ready podcast. If you have a story that you'd like to share, or you know someone who might, if you're a professional who works in the capacity of helping people start and grow their families, and you identify as being a part of the 2S LGBTQIA plus community yourself, then please don't hesitate to reach out. We always have room for more stories to share, and there's always more learning to do.